I'm a MD PhD. I'm an MD PhD student. I am in my 4th year. I'm halfway done, and I'm getting my PhD in healthcare policy and research. And my main focus in research is social needs and treating them within the healthcare system, and in particular disparities in social need and how that impacts care.
Hi, I'm Andrea. I'm a M4 student, and I'm starting OBGYN residency this year.
Ooh. All right.
Okay, so some background on pregnancy and opiate use disorder. The leading causes of pregnancy-associated deaths are homicide, suicide, and drug overdose. Postpartum overdoses increase 7 to 12 months after delivery. And so we chose to look at psychiatric comorbidities because psychiatric concerns increase the risk of pregnancy-associated overdose death. A significant number of individuals with substance use disorders have one or more psychiatric diagnoses, which can exacerbate substance use. One study found that 77% of pregnant women who died of a drug-induced overdose had a psychiatric condition. So medications for opiate use disorder is a safe and recommended treatment for opiate use disorder, and treatment for psychiatric comorbidities is also best practice.
So this leads us to the questions we were asking. So like Andrea said, we know that MOUD affects pregnancy, or opioid use disorder affects pregnancy, and we also know psychiatric comorbidities affect pregnant women because they're people too, as Dr. Martin says. And so we really wanted to focus on that interplay between psychiatric comorbidities and opioid use disorder, but particular in this population because it's pretty understudied, and in particular, it's not well known how opioid use disorder treatment changes in the postpartum period, particularly in the late postpartum periods when the risk actually increases. So understanding how treatment is going during this time is important, and understanding how these comorbid conditions like psychiatric comorbidities impact treatment is also really important for care. So that got us to thinking about the current project I'll talk to you about. So this data comes from a larger parent study, and this parent study identified any pregnant or postpartum individual who received any type of buprenorphine at VCU between January 2017 and March 2020. And this could be an individual started on buprenorphine at VCU. It could be someone who continued their buprenorphine, so it's any receipt of buprenorphine. And it was in either inpatient or outpatient setting, so it didn't have to be in a particular setting. And once an individual was identified and this was from EMR data from VCU. So once someone was identified, we conducted chart reviews on that individual from the time that they were identified until they were 52 weeks postpartum, or that they discontinued buprenorphine for at least 8 weeks. So we did these chart reviews at 4 weeks intervals for everyone. And we also supplemented it with the prescription monitoring program, which reports buprenorphine prescriptions across all different providers. So even if they weren't getting it from VCU after that initial contact with VCU, we could note their use from other providers. So that's the parent study. So essentially we have this group of 233 individuals who, from the time they were pregnant, they were getting chart reviews done every 4 weeks through their pregnancy, and then 52 weeks postpartum, or whichever came first, they discontinued buprenorphine for at least 8 weeks, which was 2 review periods. So our secondary analysis we were curious about the postpartum time. So to answer this question, we had to get individuals who remained in the study until they delivered, and until they delivered with buprenorphine. So like I said earlier, if someone discontinued buprenorphine for more than 8 weeks, we no longer did chart reviews on them. So the cohort for this analysis specifically included those who made it to delivery, were on buprenorphine during that 4-week period that they had the child, and then remained in the sample for at least 1 week postpartum. So those were the inclusion criteria. And once we got those 3 inclusion criteria, it left us with 142 individuals. And so the questions we were asking, like I said, focused on psychiatric conditions and treatment. So our dependent variable was weeks until buprenorphine discontinuation in the postpartum period. So we were curious about how many weeks did they stay on buprenorphine after delivery? So when did they stop? And if they made it to 52 weeks postpartum and they were still on buprenorphine, then they were considered censored at that point and to have continued for the whole follow-up period. And then our independent variables, we had a couple. So the first one was psychiatric comorbidity, and this was determined at the time that they were enrolled in the parent study. So that was during their pregnancy when they first made that initial contact with the healthcare system, or with VCU specifically. And it was a yes or no variable, and it was a yes if they had any of the following conditions, including ADD, ADHD, anxiety, bipolar, depression, schizophrenia, and PTSD. And then we had a group of time varying variables. So remember that I said that these chart reviews were done in 4-week intervals. And I should have said for the dependent variable, for that outcome variable, the week of discontinuation was that last week of the individual's last 4-week period, because once they stopped taking buprenorphine, we no longer did their chart reviews. So that last week of the 4 weeks was when we considered them to be discontinued. But for this independent variable, if they were, it was a yes or no about whether or not they were taking psychiatric medication in the prior 4-week interval. So if it was, for example, week 16 postpartum, and they took medication in week 11 postpartum, then they would be a yes for psychiatric medication. So it was looking back at that 4-week interval to see if they were taking medication. That was one variable. And then the second variable was, were they attending behavioral or group therapy? And then a third variable was a combination, where was any treatment effective? And so, like I said, that was a yes or no. And then we had a couple covariates, including race, white and African American were how everyone identified. So those were the categories that we included in this analysis. Incarceration status at the time of delivery, it was dichotomous, yes or no. And then the time spent receiving buprenorphine before delivery. So this was, once again, during their pregnancy. How long were they taking the buprenorphine during their pregnancy before delivery? And then the methods I used, I wanted to look at discontinuation in a couple different ways. One was a more simple measure, a dichotomous measure of, okay, did they make it to that year mark? Did they take their buprenorphine up until the year postpartum, or did they not? So that was the dichotomous, and I used chi-squareds and student t-tests to assess the relationship between that dichotomous, did they make it to 52 weeks or not, and all the other variables. And then I looked at survival probability curves, Kaplan-Meier curves, and then I used a Cox proportional hazards model, and including time varying factors, which was the medications and therapy variables. And this, for the Cox proportional hazards, the outcome was that time to discontinuation. So the weeks postpartum to discontinuation. So this allowed me to look at the data in a couple different ways and really try and get to what is this relationship between psychiatric comorbidities and treatment and continuation. So our results, like I said, I first broke it down into, did they discontinue their buprenorphine within that first year postpartum, or did they make it all the way to the 1 year postpartum? And everyone identified as female, so I didn't have that. And then I looked at Black versus white individuals, so race. It was a majority white population, and whites tended to discontinue their buprenorphine more than Black individuals, and this was significant at p-value of 0.05, less than 0.05. The duration of OUD treatment before delivery, this was in mean weeks and then standard deviation. So not surprising, those who continued their buprenorphine had a longer duration of treatment before delivery than those who discontinued within that 1 year, although it wasn't statistically significant just in this student t-test. But and then I looked at incarceration at the time of delivery. Most of the individuals were not incarcerated, so 78% were not incarcerated, but there was a difference in incarceration. So being incarcerated was associated with greater discontinuation of buprenorphine within 1 year postpartum. It's close to 0.05, but it was significant. And then I looked at our variables of interest. So this was those 72% of individuals within our sample had a psychiatric comorbidity. And I forgot to say, the sample got reduced down to 138 individuals because I did a complete cases analysis. So there was 4 people who were missing either race or incarceration status. So they were dropped from the analysis. And then so psychiatric comorbidity was not associated with this dichotomous variable, although there was a greater percentage of individuals who continued buprenorphine who did have a psychiatric, who continued it for the whole year, who did have a psychiatric comorbidity. And then this one's a little bit tricky to wrap your mind around, but so this was the proportion of someone's 4 weeks intervals that they had a lagged psychiatric treatment of any kind. So for example, if they had 10 4-week intervals, so they were on buprenorphine for 40 weeks, how many of those weeks did they have a psychiatric treatment in the 4 weeks prior to that current week? So if they had psychiatric treatment every time in the past 4 weeks for those 10 intervals, then it would be 100%. If they had no treatment, it would be 0%. And you can see here that there's individuals who continued buprenorphine for a full year had more of their weeks have a psychiatric treatment in the past 4 weeks. And it's marginally significant, it's 0.063. But then if you, got too excited. If you look at just the medication, so this second one should say medication, not treatment. But if you look at medication by itself, there was a significant relationship. So they had greater proportion of those weeks have a medication in the past 4 weeks than those who discontinued their buprenorphine within 1 year postpartum. But that relationship was not significant with therapy. So therapy had no significant relationship when you're looking at therapy in the past 4 weeks. And it clinically, I think it kind of makes sense. I'm not a doctor yet, but if you think about the time it takes for a psychiatric medication to work, it's typically like 4 to 6 weeks. So having a lagged effect makes more sense than a therapy, behavioral or group therapy, or individual or group therapy, where the effect may be more immediate and be quicker to kind of disappear over time. So then I looked at the survival across time by psychiatric comorbidity, and this is survival probability, but you can think of it as the probability of continuing buprenorphine. So what is the probability that someone continues their buprenorphine all the way to the 52 weeks? So as you can see here, it's not zero because we had a proportion of individuals who stayed on their buprenorphine all the way to 52 weeks, but it does decrease over time. And the probability that they're staying on their buprenorphine is lower for those who do not have a psychiatric comorbidity than those who do have a psychiatric comorbidity. So that means, for example, at 30 weeks, someone who has a psychiatric comorbidity has a higher probability, higher odds of being on their buprenorphine than someone who does not have a psychiatric comorbidity, which kind of surprised me. But it does make sense if you're thinking, okay, they have kind of more reason to stay engaged in treatment because they're getting a benefit both for their psychiatric condition and for their MOUD. And this is just the adjusted analysis. You can see when you adjust for all the other covariates like race, incarceration at delivery, and then time and care before delivery, that difference between those two groups, those that don't have a psychiatric comorbidity and those that do have a psychiatric comorbidity, the difference is even greater. So that's the difference between those two. And then we looked, okay, so we think that psychiatric comorbidity might have this protective effect on buprenorphine discontinuation. So then we looked at treatment. So this is unadjusted, but these are having psychiatric treatment in the prior 4 weeks. So as you can see here, so this is once again survival probability, which you can think of the probability that you're still on buprenorphine at whatever week you're looking at. So for example, once again, at 30 weeks, those who took psychiatric treatment in the past 4 weeks had a higher probability of being on buprenorphine than those who had no psychiatric treatment in the prior 4 weeks. And this was similar for medication and for therapy. I broke those into 2 groups. All right, so then we get to the regression part. This is the third way we're looking at this association. And so this is the model. Oh, I forgot to say one thing. With the previous survival probabilities, when we're looking at these treatment effects, those are only among people with a psychiatric comorbidity. So it's among the 100 individuals that have a psychiatric comorbidity. But back to this, these are among everyone. So this is 138 individuals with all the data that I need. And so this first question is, how is psychiatric comorbidity impacting the time to discontinuation of buprenorphine? And we can see here that there is lower odds of discontinuing buprenorphine among those who have a psychiatric comorbidity than those who don't have a psychiatric comorbidity. And this is a significant relationship, suggesting that there's this protective effect for psychiatric comorbidity against buprenorphine discontinuation. And these are just the other variables that I adjusted for. They were significant. So those who were incarcerated had a greater odds of buprenorphine discontinuation than those who were not incarcerated at the time of delivery. This one was interesting. So in this analysis, white individuals had a higher odds of buprenorphine discontinuation than Black individuals, which to my knowledge is incongruent with prior research. And I did check to make sure I didn't code them in reverse. But if people have thoughts on that, I would love to hear them, because I couldn't think of a great rationale as to why we're finding that. And then I did 2 models among those who just had psychiatric comorbidities. So like I said, that was 100 individuals. And what I found, first I looked at any kind of treatment in the prior 4 weeks for that psychiatric comorbidity, and there was a significantly lower odds of buprenorphine discontinuation for those receiving treatment in the past 4 weeks than those who received no treatment. Which is kind of what you would expect. That's exciting. It looks like treatment is having a positive effect, which is what we like. And then I looked at, in the same model, okay, what is the effect, what's the marginal effect for therapy, behavioral therapy in the past 4 weeks versus medication therapy for psychiatric comorbidities in the past 4 weeks. And what I found is that medications was significant. So there was significantly lower odds of buprenorphine discontinuation if you took medication in the past 4 weeks, but there was not that significant relationship with therapy. So that's like behavioral or group therapy. And we did some modeling earlier where we included behavioral therapy during the interval, so at the week that they discontinued, and it was protective, significantly protective against discontinuation, which might suggest this different kind of time effect that we're looking at, medications having effect when you're looking at it lagged, and then therapy being effective tool more in the moment, which makes sense clinically in my mind. All right, so limitations, we didn't take into account the duration of treatment of for psychiatric comorbidities in the postpartum period. So like I said, it was just a simple yes or no, did you get treatment in the past 4 weeks? But it wasn't, how long have you been on the treatment? Is it consistent? Is it inconsistent? We didn't get to that granular detail. The sample consists of a particular clinic and a particular set of patients, so it limits the generalizability, particularly because this is an institution that has an awesome integrated practice for these patients, so it might be even more effective than traditional clinics. I didn't write this on here, but it's also all EMR data, which makes it incomplete in a sense because you're not getting any record, particularly for mental health, who people often use outside providers for. You're not necessarily getting that documented. And then it's just a small sample, but it's a great sample because it's over time. So, all right.
So for the discussion, our results suggest that having a psychiatric comorbidity protects against buprenorphine discontinuation, and treatment for psychiatric comorbidities protects against buprenorphine discontinuation, but may depend on the type of treatment. So we think that it could be that because people have psychiatric comorbidities, it allows them to get plugged into receiving healthcare services in general, and it really stresses the importance of having integrated healthcare service delivery, that women have and all people can have their mental health concerns treated at the same time as they're getting their opiate use disorder treated. So future directions, future work should look at perinatal factors, and also the study should be repeated within a Medicaid population.
And these are just references. I think that's all.
Awesome, thank you so much. Team, it was a great presentation and very helpful and such great work. I'll really using this data set. You have lots of claps and from the audience I can see. And this data is part of the abstracts that Bhushan presented at the beginning that have been accepted at ASAM and SASCOG based on for the different treatments that we looked at. So yes, we're excited to be able to share this with others. I'm gonna open it up for any comments, questions, etc. It looks like Annabeth kind of started us off, so I'll read hers. That's in the chat for you two. So Annabeth is asking, were the Black participants more likely to have a psychiatric comorbidity than the white participants? And she's wondering if that might explain the quote unexpected outcome that we saw initially with the diagnosis results.
Give me 1 second because I actually did that and I can't remember the numbers. So hold on.
Yeah, I just like Hannah said, any other thoughts on the racial difference are welcome, because you're correct, Hannah, that the data is coming out with obviously much larger sample sizes than we have from the different Medicaid studies that have been done in other states have showed generally the reverse finding. However, I will note that a lot of those studies that have found the worst treatment outcomes in general for Black birthing parents than white birthing parents, a lot of times have been in samples that have a small minority of Black parents, and ours is kind of much smaller than what we have. So that might be one thing, but I really would love it if anyone else has any other things to say in addition to what Annabeth said.
Yeah, so this isn't, I haven't done like statistical testing, but there's 74% of white individuals had a psychiatric comorbidity and 68% of Black individuals had a psychiatric comorbidity. So they're fairly even. So I'm not sure, but that's definitely a good thought.
Any other feedback, questions, or anything that needs clarification? Because that will help us know as we're writing it up from anyone.
Hi, this is Deshonda. Sorry if you can't understand me. I have a mask when I'm out in public, but I just wanted to say, please be like conscientious of the discussion when you're talking about the differences between the racial groups, and making sure to acknowledge that it's not a genetic based categorization, but it's a social categorization. And my question about the literature search was it focused on Black mothers, Black parenting individuals, or the Black population in general, when you were looking at differences between white and Black for the outcome?
Dr. Martin probably is better to answer this one.
Yeah, all the studies are, Deshonda, are just not great yet. They've, actually Hannah and I were just talking about that this morning, right? With the studies that have been coming out just in the last 2 years that have actually started finally, measuring variables related to structural and systemic racism, and then leading those over to results for opioid use disorder treatments. None of that has been done in the pregnant postpartum population yet. But they're starting to do, some other people, some other groups, we actually just reviewed some of the papers this morning. Luckily, I've started doing that for the general population. Hannah and I are working with the team, with Aaron and others. We're trying to start looking at that in Virginia Medicaid data. So stay tuned. It will be a while, but we are on track for that. So, but yes, unfortunately, the studies that are out there just are limited. So I think right now, I think we just have to state our findings, and then we can use this as a springboard for discussion like we did in the other paper, Hannah, that we did recently, just saying, hey, this is a call for better research to be done that does exactly what Deshonda said, and measuring race, not as a variable itself, but that other variables are related to racism, which we don't have in this data set, but other data sets we can get that.
Right,
Yeah,
and I understand the lack of information in the area, in new lines of research, and developing better methods to recognize that. And I was just saying, I was just wondering about looking at the general population and saying that we could still use that information but also recognize that there may be differences for Black and white parenting individuals with opioid use disorder.
Yeah, for sure. That's helpful to think about. And I think it also shows like a positive thing that with good clinical support, like I think it points more to the fact that like it's a poor support for individuals, because once you're in an environment where you are well supported, the disparity might be mitigated that you normally see in other literature.
Yeah, no, I think that's great. And thank you both for your presentation.
I think that was great feedback so far. I'm going to send you my notes, but a couple things that I thought of that I hadn't thought of, even though I've heard the results already, is I think it'll be great to play up the advantage of the analysis, which is that you did look at the time situation, right? When they got treatment in relation to the observation period of interest for the outcome. Because a lot of these studies that are done, from clinical data, not from billing databases, just really put it all like, did you get any treatment anytime? And they don't look at the time situation. And anyone who works in this field clinically knows that how healthcare systems deliver care changes significantly from pregnant, delivery, hospitalization, and postpartum, like the intersections and the interfacing. So you really can't collapse pregnancy, delivery, and postpartum data because how people are accessing clinical care is so different. So I think that's a big advantage to play up in the paper. And maybe it's not perfect the way we did it, but in my opinion, it's better than doing nothing like these other studies have done before. So I'm happy about that.
Thank you.
Great. Anyone else have any other feedback, comments, questions, anything else? Okay, then we'll transition into our journal club to end.